Good morning, Chairman and Co-Chairman, all staff, and my colleague. I'm Chonlathan Boontan from Paris General Hospital. Today, I'm proud to present about the acetabular labral tear diagnosis and update on management. Here's the outline for today, starting from introduction, hip versus shoulder, how to diagnose, update on management, and final take-home message. Back in history, humans used to walk with 4 legs, then mankind evolved to walk with 2 legs. So the shoulder joint tend to be more mobile, but the hip joint tend to be more stable with higher degree of joint coverage. The difference between acetabular labrum and shoulder labrum is acetabular labrum is thicker and wider. For acetabular labral tear, I'm going to abbreviate to ALT. So ALT was first diagnosed in 1957 in irreducible posterior hip dislocation patient, and then was first diagnosed with arthroscopy in 1986. Nowadays, we got more frequently diagnosis because of the better imaging and arthroscopy techniques, so came the higher prevalence. ALT is quite hard to diagnose due to overlapping and sign symptom, or even some other hip condition. History taking and physical examination play an important role in identifying concomitant hip pathology in our patient. In order to diagnose this, top 3 clinical presentations were first anterior hip or groin pain, more than 90% of the ALT patient, following with the mechanical symptoms like clicking, locking, or catching, and then the anterior thigh pain about 59% as the third one. Other clinical presentation can be hip instability or even pelvic floor pain in female. As difficulty of diagnosis, the physical examination has found 98% accuracy in intra-articular hip pathology, but specificity of ALT is far less accuracy and need to be paired with the other imaging modality. For anterior hip impingement test had accuracy as 80% and 99% sensitivity, but for specificity is very low as 24 to 26%. As shown in the video, patient was lying supine with the hip knee in 90-degree flexion. The hip is internally rotated and adduction force is applied or feather position. A positive test is a pain provocation in anterolateral hip or groin. The newest examination proposed in 2023, the Arlington test is performed with the patient laying supine on the examination table. We put one hand is just distal to the popliteal fossa and another hand is at the ankle. The affected hip is brought from the Faber position and then slowly moved to the feather position. And then we provide the bowing motion from Faber to feather. Occurring the pain or clicking symptom is considered positive. Another test is the twist test. We will instruct the patient to stand with both knees slightly flexed while creating the windshield wiper motion. Twist like a Tesla test in the knee meniscus. Internally and externally rotate the hip, or you can tell the patient to focus to check their glute, but this is not mentioned in the paper. Next, the same windshield wiper motion performed only on the affected leg in single leg. Any pain or clicking symptom is considered a positive. After the currently reviewed the hip examination like anterior impingement test, scour test, or internal rotation overpressure test, all 3 got high sensitivity, about 90 to 100% sensitivity, but their specificity is still low. From 2 novel hip examination by Dr. Ardip in 2020, the Arlington test is more sensitive than the traditional impingement test at the 94%. And the twist test is more specific than the traditional feather test at 72%. For the investigation, although the ultrasound has the lowest diagnostic value, it has advantage being inexpensive, quick, non-invasive procedure, and dynamic evaluation. There was a paper studying on FAI with labral tear. They used 3D CT and CTA as the main studying imaging, and it had high sensitivity, specificity, and accuracy too. For MRA, it has the highest diagnostic efficiency in ALT. Moreover, it can detect small size labral tear, cartilage, and capsular defect. For MRA finding as the third picture shown the contrast, field cleft extending into the labrum or acetabular labral interface. Yes, hip arthroscopy is considered the gold standard for diagnosis because we can directly see the labrum with the details about tear's location, size, and severity. It has diagnostic therapeutic potential too, but limitation is invasive. Hip labral tear first described by Lake in 1996 in terms of morphology of lesion, but nowadays we use modified Beck scale to classify the hip labral tear into 6 categories based on MRI arthrogram as shown in the table, which can determine the labral tissue quality and guide the treatment. The example picture in the first column shows Beck 1, which is normal. The second column is Beck 2 degeneration. The third column is grade 3 controllable detachment, with probing in arthroscopy show detached controllable junction. The fourth column is grade 4, the full thickness ALT. The arthrogram show contrast in support the controllable and controllable osseous junction. Arthroscopy show complete labral avulsion from acetabular limb. The fifth column is grade 5, the complex ALT. The MRA show contrast absorbed within the labrum. The arthroscopy show a complex tear splitting in the longitudinal axis. And the most right-hand side column is grade 6. The ossification is acetabular osseous metaplasia within the labrum. So we will step into the treatment, which is divided into the unoperative and operative treatment. As you know, all the patients start with the conservative treatment. There are lifestyle modification, rehabilitation, and medication, both pills and injection. As you know, the main point is to avoid further injury like anterior hip impingement position, high impact activity, or deep hip bending or repetitive rotation. The rehabilitation to treat ALT still lack of the high level evidence, starting with the range of motion exercise which can perform either actively or passively. Core muscle stabilization, hip muscle strengthening, for example, side-lying hip abduction or clamshell exercise, and lower body flexibility as well. For intra-articular hip injection, for a PRP injection, there is pilot study conducted in 2019, found statistically improved in modified Harry hip score, pain relief function in ALT patient, but in only a short-term period at 2, 6, and 8 weeks after PRP injection. And in 2020, there was meta-analysis found no significant difference on modified Harry hip score after 1 year follow-up in ALT patient. For steroid injection, there was a pilot study from last year, found no difference in pain reduction in 2-week follow-up. For hyaluronic acid injection is still limited use in ALT. For outcome of non-operative treatment, there is one interesting study show that in the patient over 50 years old, in 2-year follow-up, the total hip arthroplasty rate is similar in the operative group and non-operative group. And in general population, almost 50% has no pain improvement. Almost 70% still limit their activity. About 40% considers to surgery. Anyway, long-term follow-up is necessary. So we go to the operative treatment, which indicate in 3 to 6 months failure of conservative treatment. And yes, minimal invasive surgery is now gold standard, and there are 3 options as shown, and we will go one by one. For the first one, the selective debridement with the labral represervation, indicated in the stable and viable labrum. For the outcome, there is no statistically significant difference compared with the repair group for 2, 5, and 10-year follow-up. Report in the patient-reported outcome, Harry hip score, and hip arthroplasty conversion rate. There is an algorithm proposed by Dr. David to guide us which type of the labral should be repaired or reconstructed. If there is a tear with good tissue quality, we perform a labral repair as a gold standard of treatment. In case of irreparable labrum, we inspect in the controllable junction integrity. If the controllable junction is preserved, we do the augmented repair. But if not, we do the segmental reconstruction instead. Lastly, if the labral defect is too large or could not be repaired, we will perform the circumferential reconstruction with graft. For arthroscopic labral repair is standard for unstable but still viable torn labrum, as shown in the picture as the significant architectural disruption, the good candidates to repair is high demand patient with simple unstable tear without previous hip surgery. There's study comparing loop as shown on the left side and pierce technique shown in the right side. They found that there is no different outcome regarding hip score failure rate and revision rate. The Anchor first modified toggle suture technique was introduced in 2023 using the suture passer through the torn labrum and then pull out under its own arch to create the toggle as the video to control the labral inversion or in-route repair. And the result, we got the suction seal effect back. For the arthroscopic labral reconstruction, goal is to improve the suction seal effect, contract pressure, hip stability, and remove the pain generator. Reconstruction reserved to the irreparable labrum, which defined as the irreparable hypertrophy, degeneration, complex tear, or prior debridement. There is study in 2024 by Dr. David showed that the reconstruction in irreparable labrum improved 5-year modified Harry hip score, and the outcome is good because even in irreparable tissue, the rate of hip arthropathy is not different with the repair group in 10-year follow-up. To take home message, to diagnose the ALT is still challenging. We have to combine all history taking, physical examination together with imaging. Keep in mind that once ALT is suspect, there always be some underlying hip problem. So find concomitant hip pathology and treat it too. MRI arthrogram is the investigation of choice. Even hip arthroscopy is gold standard, but it's considered invasive. One ALT is provisionally diagnosis, conservative first. And in ALT back classification 3, 4, 5, which requires surgery, not less repair technique outcome are similarly effective. Thank you.